excited to be here. I'd like to introduce Dr. Stephen Kingsmore, who is President and CEO of Rady Children's Institute for Genomic Medicine, where he leads a multidisciplinary team of scientists, physicians, and researchers who are pioneering the use of rapid whole genome sequencing to enable precise diagnoses of critically ill newborns. Among his achievements, Dr. Kingsmore holds a Guinness World Record for achieving the fastest molecular diagnosis using whole genome sequencing in just 19.5 hours. So we're pleased to have him here today to discuss the state-of-the-art diagnostics in rare diseases. Dr. Kingsmore, thank you for joining us.
Super. So I'm going to talk about state-of-the-art diagnostics. The focus is on rare childhood genetic diseases. So children do have non-genetic rare diseases, but what's really different about pediatrics is that a huge component of healthcare expenditure goes on genetic diseases, monogenic conditions. I don't have a conflict of interest. Okay, we are living in an incredibly exciting time. We now know the molecular basis of 7,100 genetic diseases, and that number changes every day. We can now diagnose a genetic condition by rapid whole genome sequencing in 7 hours. Sadly, that is no longer my record. That's held by you and Ashley's group at Stanford. And also, amazingly, we can decode a genome in a research setting for less than $400. These all come together to mean that we are entering a new era of instant diagnosis of genetic disease in children. So for the last decade, my team has focused on this problem A, which was children in intensive care units who were suspected of having one of these genetic conditions. We're talking in total about 2% of the childhood population. And a characteristic about genetic diseases in children, which is different from adults, is that they have a much more rapid rate of progression. This is true in pediatrics generally, but especially in these diseases, and in particular, those that have newborn onset. And so there are literally sometimes only minutes or hours to make a diagnosis in time to save a life or save an organ. And so the goal with rapid diagnostic whole genome sequencing is to make that immediate diagnosis and minimize morbidity and mortality. This is a busy slide. If I'd shown this slide a decade ago, it would have just contained the middle line, which was the testing component. However, these days we realize that in order to achieve optimal outcomes in children, we actually need an entire healthcare delivery system in which doctors, nurses, ICU administrators, healthcare administrators, payors, as well as laboratorians are involved. Also pediatric subspecialists. And if we all come together, we can actually do what I will show you in the next couple of slides. So this is a great case. It's a fairly recent case from around the end of the year. A 14-year-old cheerleader in San Diego County finished her supper and then felt dizzy and fell on the floor and was pulseless. Mom started CPR. She was further resuscitated when the emergency medical services arrived, but they couldn't get a stable pulse. And what happens in one of these code blue situations is there's a formulaic approach where you go from intervention to intervention in a highly prescribed manner. And every doctor and every EMT knows this and is trained to provide it. So she goes all the way through this, including 5 episodes of cardioversion. She's transported to an outside hospital. She still is not recovered. This resuscitation continues. She's transported to Rady Children's Hospital. We are the subspecialist hospital for our part of California, mainly San Diego and Imperial counties, but also southern Riverside County. And she continues to be unstable and unable to maintain her blood pressure. So a difficult decision has to be made, which is What do we do? She's put on a heart-lung bypass. It's called ECMO, extracorporeal membrane oxygenation, because she has refractory ventricular tachycardia. That buys her probably a week, maybe 10 days, to figure out what's wrong and to fix it. Now, she is positive for a viral infection. It's a rhinovirus, common cold, that can cause viral myocarditis, inflammation of the heart muscle. So that is the clinical diagnosis. And the treatment for that is intravenous immunoglobulin, and then possibly also adding corticosteroids. And typically this is a self-limited illness, and the patient will recover over about a month. Her echocardiogram shows that her heart has essentially lost all pump function, however, 3% ejection fraction versus a normal, which is 60 or 70 in somebody like this. So that treatment is started for the presumptive clinical diagnosis, but the astute physician also orders a genome. It turns out that indeed, this young lady does have a genetic illness. It's a dominant disorder. It occurred de novo in her, so it was not present in her mum or dad. And the affected gene is lamin. It's one of the structural proteins for cardiac muscle. And so her ventricular arrhythmias are a result of dysfunction of lamin A in terms of controlling cardiac contractility. This is a typical presentation. She's maybe a little bit young, so it typically presents in young adulthood. She's 14. And it may or may not be that the viral infection is what triggered this very abrupt onset. So it may be contributing. We don't know. Why this is so important is intravenous immunoglobulin won't do her a button of good. And she's on an ECMO machine and she can't stay on that for long. Now, in a normal course of events, this would not have been ordered, this testing, until sometime down the course when she did not respond as per usual. If that had been the case, she probably would have died. Instead, that day, she's listed for cardiac transplant. She has it on day of life 7. Is extubated on day of life 9 and goes home just a couple of weeks later. That was about 4 months ago, and she's doing just fine. She does not appear to have any cognitive impairment, and obviously with her newly transplanted heart, she no longer has that cardiomyopathy, nor will it recur. Heart transplant, in her case, is curative. This is the miracle that's occurring all over the world now, where hitherto fatal genetic diseases are fixable, provided you diagnose them in time. So, back to the paradigm. You've now understood how big of a problem this is, and how a rapid diagnosis leads to prompt initiation of treatment and thereby reduction in morbidity or mortality. There are now 31 published studies that come to the same conclusion, which is that overall about 1/3 of children who receive a rapid genome or a rapid exome, if they have a suspected genetic disease and if they're ill enough to be in an intensive care unit, on average 37% diagnosis, 29% change in management. So that's just about all of those who are diagnosed, 18% change in outcome. Those numbers, if you're a doctor, are mind-numbingly amazing. We are used to living with new interventions that maybe shave off 1% in terms of outcome, 0.5%, 0.1%, an 18% change in outcome is completely unheralded. This is the diagnostic revolution. So over the last 5 years or so, we have really focused on moving this from being an experimental test performed in a research setting to becoming standard of care. And we started this in California with what was called Project Baby Bear, which has now been recapitulated in 2 other states. Let me just show you the results of this study. So this was an implementation study. This was not research. It was funded by the legislature. And the goal was to see whether in real world practice, we could recapitulate what research studies had so richly shown. These are the zip codes of the babies who were enrolled. They were all less than 1 year of age. And as you can see, Children's Hospital of Oakland was one of the enrollment sites. And here's the results. And they really did recapitulate the clinical utility. So 43% rate of diagnosis and 31% change in management with a 3-day turnaround time. So yes, indeed, in the Medicaid population, which is about 55 to 60% of US newborns who are admitted to intensive care units. So it's not a small population. Again, babies are a little bit different than adults. So Medicaid is the dominant reimburser for bills of such infants. This really works. The second thing that the legislature asked us was, how much will this cost California Medicaid or Medi-Cal? And so we did a cost analysis. And as you can see on the left-hand side, we looked at 3 turnaround times. So we modeled this using a sensitivity analysis. And for all of the turnaround times, there were cost savings during that first hospitalization, and they were maximized by time to result of 3 days. We didn't model any faster than that. At that point in time, that was about as fast as was possible. Now, cost savings in first hospitalization were not the only savings that were apparent. There were also savings in ongoing cost of care and savings for the family in terms of comorbidity, anxiety, depression, lost time from work, and so on. So that overall, this was highly cost saving for Medi-Cal. And as a result, we now have a policy in California to make this standard of care. Unfortunately, that did not result in a change in payment. So the Department of Health decided that this should be covered by the DRG, which of course is a ridiculous proposition, since the DRG system only covers about 90% of the true cost of hospitalization. So adding a genome to that is not something that hospital administrators are going to permit. The good news, however, is that 3 other states have now joined suit. That's Oregon, Minnesota, and Michigan. And Minnesota and Michigan's policies are more enlightened and actually provide a separate carve-out payment to reimburse for the actual test results. And the same is true of Anthem, Blue Cross, Blue Shield, both in California and nationally. This is changing very rapidly. So those 2 newer sites of Oregon and Minnesota just enacted those policies in the last month. Okay, so that's the state of the art for diagnosis, but I don't want to finish there. There's more to come. There's a second bottleneck, bottleneck B. What we have found as we have now implemented this nationwide in 80 children's hospitals is that doctors often don't know the management of these rare and ultra rare conditions. I have a new term for you. It's the therapeutic odyssey. We thought we were done with the problem with the diagnostic odyssey. Well, we're not quite. So we need a solution that upskills frontline MDs so that they actually become masters of rare disease management. Now, it's not their fault because the evidence supporting many of the treatments for these diseases is interspersed throughout the literature. And so a busy physician has to go online and do a PubMed search and read through articles if they're to find the most timely information about treatment. That's obviously not tenable in an intensive care unit. So with support from NIH, we put together a system that's now available. You can look it up on the internet, called Genome to Treatment. And we followed the so-called Delphi method to adjudicate every treatment for every genetic disease that we thought had an effective therapy. And we did this also by integrating 13 information resources that have valuable information sets that physicians want to know about their patients and may not be familiar with. And one of the examples is shown on the right, Ornithine transcribalise deficiency, which has about 10 different effective therapies. It's very unlikely that a pediatrician would know them all. And not only do they need to know what the treatments are, but what are the indications, what are the contraindications, how soon should you start the treatment after diagnosis, and then not only is it efficacious, but how efficacious, and what's the evidence to support that? Is it just case reports? Are there any randomized studies? Has it been FDA approved? Physicians need to know all of this information so that they can weigh up the risk-benefit ratio for their individual patient. You know very clearly, undertaking a heart transplant is not a decision that's considered lightly. Starting a dietary supplement is much simpler. So physicians need to know that context as they consider managing a patient acutely. Now, this is not to say we don't have subspecialists and super specialists who are the typical folk who manage these patients in the long run. The issue is there may be a time lag of days or weeks before you get that subspecialist consult. And in particular, as we get outside the major urban centers and into more rural or agricultural areas or less densely populated areas, where you may have to go hundreds of miles to see a subspecialist. So this is now completed. There's the URL for it. We screened 563 diseases. We retained 421 as indeed having an effective therapy. We looked at 10,000 different possible treatments and retained 1527. And you can see their breakdown in terms of surgeries like transplant, dietary supplements, drugs, devices, and others. This is really exciting. We now have a 1-2 knockout punch. We have both rapid diagnosis and an ability to upskill frontline MDs so they can practice like a super specialist in managing those critically ill children. But wait, for today only, I have a special offer. We have a third previously unannounced focus. And this is something that we started again with NIH a few years ago. There was a feasibility analysis of using genomic sequencing for newborn screening. Why am I so excited about this? Well, it's not a really good time to diagnose a child with a genetic disease when they're critically ill in an intensive care unit. The best time to diagnose their disease is before symptom onset, either at birth, if symptom onset is going to happen soon, or if indeed there's a treatment that can be started at birth that will completely prevent the disease, such as is the case with spinal muscular atrophy type 1, or just waiting until symptom onset with careful screening to pick that up as early as possible. So we have now built this. We haven't really talked about it, but I wanted to give you a heads up. We'll look at it very briefly. On the bottom are the organizations who have joined us in building this system. So a couple of things drove us to do this. First of all, we built out this system for diagnosis in a scalable manner, and we had built out this system for treatment guidance. Well, it turned out that we didn't need to do too much to translate that into a newborn screening system. It uses the same components, the same technologies. The difference is that now we are looking at a highly qualified subset of variants in a highly qualified subset of diseases, only those that cause critical illness, only those where we understand the natural history, only those where we have an effective therapy, and we know that starting the therapy early improves outcome. Those conditions meet the criteria established in, I believe it was 1968, the so-called Wilson and Youngner criteria for newborn screening. We intend to clinical trial this both in the NICU, but also in the newborn nursery. So I have two proofs of concept. We've just finished these in the last couple of weeks. The first was to examine it in the UK Biobank. This is an amazing resource. You can pay for access to this, and we looked at 30,000 known disease-causing variants, and we said, what's our probable positive rate in these adults? And it was 0.7%. That's too high. That would give us a low positive predictive value. However, by blocking only 5 variants and 3 risk factor disorders, we got that down to 0.2%, which is in the range that we needed it to be to give us a positive predictive value of 50%. We also looked at 2,000 or so diagnosed babies, or babies who had received rapid whole genome sequencing in an ICU admission, who were suspected of having genetic disease. And we found that this very focused screen had a 55% sensitivity compared with diagnostic rapid whole genome sequencing. These results are good enough that we're now moving into the next phase, which is to set up a clinical trial that's adequately powered to prove out both the clinical utility and the cost effectiveness, like we did over the last few years for diagnostic rapid whole genome sequencing. So last slide. Diagnostic rapid whole genome sequencing is an effective first-tier test for genetic disease diagnosis in hospitalized children with diseases of unknown etiology. It's revolutionary, and it's starting to become widespread as it's reimbursed. Second of all, we've built a brand new system to bridge for frontline physicians the gap in their knowledge, so that not only can they order a genome-based test and get a result, but they can immediately translate that into effective individualized therapies, so precision medicines. This is well poised to be built upon as a new slew of drugs is developed, which I'm sure Tina talked about in her first talk. And lastly, also in light of this impending revolution in terms of genetic therapies, we are in the process now of building newborn screening by rapid whole genome sequencing as a new starting point to just eliminate the diagnostic odyssey for conditions for which an effective therapy is available. So I am on the prowl looking for collaborators. In order to accomplish what I just outlined will take a village, and it requires all types of different skill sets. And so I am very keen to have this be trialed in California, obviously, and to have representation from all of these groups. I haven't acknowledged everybody who contributed to this, unfortunately, but this is a good chunk of them. And I also want to acknowledge support from NIH. Thanks very much.
Great, thank you very much, Dr. Kingsmore. Wow, that was amazing. A very compelling case study you had there too. I have a questions from the audience. And the first one is, what are the reasons that newborn screening by this RWGS is 55% sensitive to known conditions? Are there changes that can be made to dried blood spot amount and handling that would increase that sensitivity? Or is it possible that a blood draw could become more the standard of care that's much more sensitive?
Yeah, good question. This has not got anything really to do with the assay It's got to do with the interpretation. So in diagnostic sequencing, we can have a very broad search. Why? Because we have phenotypes. We have detailed phenotypes on the baby's actual symptoms, signs, and lab values. And so we can survey all 7,100 known genetic diseases, and we can also interpret variants of uncertain significance. In a screen, you got none of that. You've got an ostensibly healthy baby, and you have to have a bulletproof set of variants where you've culled out all those variants of uncertain significance, because you have to have a high positive predictive value. That comes at a cost in terms of sensitivity, but the good news is, with time, we're building this as a learning system, and with time, our knowledge of disease-causing variants is getting better and better. 55% is actually, to me, really good for now.
Yeah, great. So as a follow-up question, someone said it's very interesting about the phenotype. Do you think family history will be able to appreciably increase the sensitivity for the whole genome?
So here's the really exciting thing. Once we have performed a genome at birth, it's not like we dump that data. We will have a system for keeping that data in your electronic health record. And that's where the answer to that question becomes. There'll be a secondary use case that if you and your doctor agree that you would like to look at the genome, let's say you start to get shortness of breath or anemia or liver dysfunction, you can get an interpretation of that genome, or something pops up in a family history. You can get your genome reinterpreted in a directed manner that's informed by your symptomatology. So that's a beautiful use case where no longer do we have that incredible rush to get a genome. If you become critically ill, your genome's on file. We just need to reinterpret it in light of the new symptoms.
Going back to your case study, how often is whole genome sequencing diagnosis done if a patient has a clinical diagnosis like the infection?
That's another really good question. And there is definitely a learning curve. What pediatricians are learning is that clinical diagnoses are just what they are, which is clinical diagnoses. You know, we as clinicians are really proud of our skills and our ability to formulate a differential diagnosis. What we're finding, though, is we need data-driven diagnosis, right? A genome, once it becomes reimbursed, is going to be such a simple way of ruling in and ruling out some of those things that are lower down on the differential diagnosis list because they're uncommon, but giving great peace of mind to the pediatrician and to the family that those rare treatable conditions have actually been evaluated. So that just wasn't possible hitherto. And so we're seeing increasingly that doctors are starting to become more critical of their clinical skills as they get familiar with the technology and are moving from genome being last tier test to being first tier test.
So the whole genome sequencing is a large amount of data. How are you planning for portability of large amounts of data? Is this for the cloud?
That's
Do you have
a
hopes
great
that
question.
who will support financing this?
Yeah, so that's actually two questions. So we thought a lot about the data management system. So for this to work, we need every race and ethnicity and ancestral group to be represented in sufficient volume to know the allele frequencies. So we're really talking here about millions of genomes. So you need a very robust data management system. And I didn't have time to talk about it. I only had 30 minutes, but we have that. We've built it. It's called a sparse array data management system. And it makes use of the fact that 99.8% of the genome is reference. So in reality, we don't need to store 99.8% of the data. There's no value to it. So that's a solution that brings the cost, the incremental cost, down to 6.6 cents per new genome added, which is pretty good. And yes, it's on the cloud, it's on AWS. which also
Great.
means we can have data aggregation somewhat worldwide. Who will pay for it? We're trying to figure that out. It's a huge undertaking, but we've got a huge amount of interest from pharmaceutical companies who are very invested, obviously, in getting their new excellently effective therapies, particularly gene therapies for these diseases, actually prescribed in children who need them.
That's great. Well, thank you so much for joining us today. In the interest of time, we must move on. Perhaps I can pass along any further questions that I've received from our audience.
By all means.
All right. Thank you so much.